the Standards for After Hours and Medical Deputising Services was released earlier this month, and these standards are available for download in PDF format from the RACGP website. We've also got it here as one of the handouts that you can download off the webinar. Today's webinar will be an information session going through each of the new indicators and discussing how services can meet the requirements to achieve accreditation against the standards. The webinar is being recorded and will be made available online on the RACGP website at a later date. So during this webinar, we will look at the standards development process, including the changes to explanatory notes and indicators in this new edition. We'll look briefly at the contents of the 3 modules: core, quality improvement, and after hours and medical deputising services. And then our expert panelists will review in depth each indicator in the after hours and medical deputising module. So we're joined today by 3 members of the RACGP Expert Committee Standards for General Practices, who will each take us through sections of the standards. And you heard from Professor Glyn Kelly, the chair of the Standards Committee, and a GP surveyor who is joining us from Brisbane. We also have Dr. Louise Ackland joining us from Newcastle. Louise is chair-elect of the Standards Committee and also works as a GP surveyor for QPA. And we have Angela Mason-Lynch, who is our practice manager specialist and co-surveyor, joining us from Sydney. So I would like to invite Simone Pike to now take us through the development process for the standards for after hours and medical deputising services.
Thanks, Angela. Hello, everyone. I'm the program manager here in the standards team at the college. So from time to time, we're asked about who actually develops standards, and as we've already alluded to, we have a standards committee who've led the development of our standards for after hours and medical deputising services. The standards committee is made up primarily of GP members, but we also have a practice manager, practice nurse, and a consumer representative to ensure that we consider multiple aspects of the standards and the quality and safety framework in which the standards operate. As mentioned earlier, we have 3 members online today, all of whom are accreditation surveyors. The 4th edition of the standards were released in October 2010, and it applied to services providing care outside of normal opening hours. It was deemed that these standards needed to be updated in order to reflect contemporary quality and safety practices. So the RACGP started developing the 5th edition of the Standards for General Practices in February 2015, which were then launched in October 2017 last year. The 5th edition of the Standards for General Practices were then used as a framework. Essentially, they've been adapted and contextualised to develop the standards for after hours and medical deputising services to make sure that they're meaningful for after hours and medical deputising settings. In doing so, the approach is to ensure that after hours and MDS services could be brought into alignment with the 5th edition standards and the new modular structure that we've developed, and I'll talk a little bit more about this later. The intent of the new standards for after hours and medical deputising is really to provide a framework for quality and safety and to help services identify and address any gaps in their systems and processes. So the 5th edition, Standards for General Practices, set out a new framework for developing successive setting-specific standards using a modular format. So you can see there on the slide, we've got our Standards for General Practice 5th edition, which is made up of the core, quality improvement, and general practice module. And that's then been used as the basis for the after hours and medical deputising standards. So what we've done is we've contextualised the core and the quality improvement modules, which are generic to a primary healthcare setting, and then adapted the after hours and medical deputising service module, which specifically looks at what is unique in that particular setting. So in order to be accredited against the standards for after-hours medical deputising services, services must meet the requirements that are set out in the core quality improvement and after-hours medical deputising services module. In terms of developing the standards themselves, there was a rigorous process that was undertaken, which included 2 rounds of stakeholder consultations, piloting, and a targeted review. The first draft of the standards was released for stakeholder consultation over 4 weeks during August through to September 2017. Feedback from stakeholders was consolidated and presented to the Standards Committee for consideration and advice. Now, based on that advice, the draft standards were revised for a second consultation and then also underwent piloting in a range of after-hours and medical deputising services across Australia. The piloting period ran for 4 weeks and included participating services and surveyors who had undergone training on the draft standards. Services had to complete a self-assessment and then undergo an on-site mock accreditation assessment with 2 experienced surveyors, which included both a GP and a non-GP surveyor. Services and surveyors also had to submit their findings, and we were specifically looking at how the standards went in terms of were they feasible, achievable, acceptable, and applicable. This provided a fantastically rich source of data on our draft standards and enabled us to take that feedback as well as stakeholder feedback to present to the Standards Committee to refine the draft further. Where new changes were necessary and introduced, particularly in relation to the indicators, feedback was sought from the pilot participants through a targeted review. The standards were then finalised through undergoing a plain English review, editing, and then released earlier this month. With the introduction of the 5th edition standards, we also introduced a number of other changes to the way in which the indicators are written. The key changes really relate to the indicators being written in such a way as to be outcomes focused and patient-centered where appropriate. When we talk about outcomes-focused standards, we're talking about what is the intent of the indicator. What are we trying to achieve through this indicator as opposed to focusing on the process? In terms of patient-centered, what we mean by that is the indicator focuses on what the patient receives rather than what the service does. So it's a different way of writing the indicators and shifting the focus. Services can choose a number of different ways that they can choose to demonstrate how they meet the intent of the indicator. And this provides services with greater flexibility to choose the systems and develop systems that reflect their particular and preferred ways of working. And it's really hoped that in doing so, it builds ownership across the practice team, which means that those systems and processes will be sustained long after the accreditation visit. There are still, however, some high-risk areas that are prescriptive, and the process is specified in terms of what needs to be done in order to meet the indicator. The other changes that we made were in relation to the explanatory notes. So the explanatory notes have been restructured based on feedback that we received following the evaluation of the 4th edition standards, and they were essentially restructured into 3 sections. The first section relates to why the indicator is important. Now, for some of the feedbacks that we received was during the evaluation of the 4th edition was that wasn't clear as to why the indicators were necessary from a quality and safety perspective. Practices and services were simply doing and meeting the indicators for the purposes of accreditation as opposed to quality and safety. So it was really important to explain how the indicators link to quality and safety. The next section relates to meeting the criterion, and that aims to provide more information and context, including ways that a practice may choose to demonstrate that it meets the indicators and/or criterion. And in the Meeting the Indicators section, it sets out a list of mandatory requirements and optional ways to demonstrate how a service can meet the indicator. It's important that the whole criterion is read together in order to fully understand the requirements. The explanatory notes provide the context around each of the indicators. Moving on to our next slide. So this is really looking at the shift towards the outcomes-focused indicators. Previous editions of the standards dictated how practices should demonstrate compliance with the standards. For example, interview or a document review or observation. And the fourth edition standards focus more heavily on the processes. Because this edition of the standards is outcomes focused, services can choose how they meet the indicator. And provided that the service can demonstrate this to the surveyor's satisfaction, the service will be assessed as having met the indicator. This approach gives much greater scope for setting up systems and processes that meet the particular needs of the service during their accreditation assessment. Moving on to the next slide, assessing the outcomes-focused indicators. When it comes to the assessment process, services need to provide examples. Surveyors will need to discuss each indicator with members of the service and be open to accepting different ways that a service may choose to meet the indicator. Services may still need to demonstrate what they've done. A conversation may not be enough. As we go through the indicators, our panelists will be able to discuss in more detail how services can demonstrate ways that they've met each of the indicators. I'll hand back to Angela.
Thank you, Simone. So to be accredited against the standards for after hours and medical deputising services, services will need to meet the requirements across 3 modules. These are core, quality improvement, and after hours and medical deputising services. The standards and indicators of the core and quality improvement modules have been contextualised to the after hours setting. The core module is made up of 8 standards and is relevant for all healthcare settings. And the quality improvement module is also relevant for all healthcare settings and is made up of 3 standards. Quality improvement includes patient feedback, clinical indicators, relates to recordings of allergies and health summaries, and clinical risk management includes safe and quality use of medicine, adverse events, managing and responding to near misses. This module is specific for after hours and medical deputising services and is made up of 4 standards. So we'll now go through the indicators within the after hours and medical deputising services module. The purpose of this section is for us to detail how services can demonstrate that they can meet the intent of each indicator. I'm going to hand over to Glyn now, who will take us through the beginning of the after hours and medical deputising services.
Yeah, thank you. So I think it's important to realise that for after hours services or medical deputising services, that they set up for emergency type consultations or consultations that can't wait till the next day. Consultations such as migraines or injuries or chest infections. They're certainly not meant for routine prescriptions, referrals or similar. So there are a number of things that in this that we need to go through. So for the service to be accredited, it must be accept appointments and provide patient care only within and for the entire after hours period as defined by Medicare, or it can be a medical deputising service that can operate 24 hours a day, but after hours it provides services within that whole after hours period as defined by Medicare. Services must also provide after hours services that are predominantly single episodes of care that are non-continuing, non-routine and predominantly of a general practice nature, and that must meet all of the mandatory indicators in the core quality improvement and after hours and medical deputising services modules. But there are a few exceptions that will come up later. Now, the first standard is around providing care in the after hours period. So when we look at an after hours service, we need to make sure that they've got a formal agreement in place to provide after hours services with their practices. I will say, however, that after hours services that are not medical deputising services do not have to have a formal agreement, but in reality they will, because if they're operating for a practice, under Standards 5, the practice itself will need to have a formal agreement, and it would be the same agreement in place between the in-house practice and the after-hours practice. The formal agreement would need to be a written agreement, and it really needs to be a current agreement. And at the very minimum, it needs to have some information in it, and that information must first off remind how they're going to tell their patients that they see that they are a supplementary service, and it's important that the patient has their own regular GP for routine care. The other part of the agreement is that there needs to be details that they will send a summary of the consultation or the event back to the patient's own doctor by the next business day. This means, of course, that they must also list the communication methods that they're going to use between the after-hours service and the patient's GP, and the area in which they are offering services and the times that they're operating. So as a surveyor, we need to look at agreement, and we need to make sure that agreement covers all the points as listed in the standards. The next one is 1.1b. Just like a normal general practice, the service needs to obtain feedback from practices for which they're providing services. Now, sometimes that can be difficult, and I can understand that, but on the other hand, there should be documentation of attempts made to obtain that feedback. The second part of obtaining feedback is not just to obtain it, but to actually do something with that feedback. And that means that they need to analyse it and show that they have considered the issues that may have been raised and discussed those issues as a quality improvement exercise. I know that some of the after-hours services tell me that they have difficulties getting feedback from practices, but on the other hand, I think it's easy for them to demonstrate that they've actually at least tried, and tried hard, not just one letter in the post. I think there's been a number of ways that they try and get that feedback. The other thing, of course, is that practices often will give feedback anyway if they're unhappy with a service. And if that is the case, then I would expect the after-hours service to keep a log of that and to also discuss how they're going to act on that. Now, to be able to provide feedback, and it needs to be timely feedback, in other words, by the next day, the after-hours service needs to collect details of the patient's regular GP and of the practice. This can be all of the GPs in the practice, or it may well be the principal GP who, if they're contacted after hours, they themselves can contact the individual GPs to get information. I know some GPs that work in normal general practices don't want to be contacted after hours, but on the other hand, I think it's important that the practice principal, at the very minimum, is contactable and is able to contact all of the GPs. But the second and main point of the details of the regular GP is so that they can provide feedback to the GP. What we're after is continuity of care. We want to make sure that our patients are looked after by ourselves in the day and by our after-hours services in the evening, and that is seamless and continuous. I certainly, as a GP, want to know if my patients have seen an after-hours service, if I need to follow up on them, or in fact, if the treatment may not have been appropriate for that particular patient at the time. The 1.1d, our service provides timely reporting of the care provided to a patient back to their regular GP practice. Now, this is really a no-brainer. If they're acting in the after-hours space, then they're acting for the patient, but also for the normal GP, and the GP needs to get that information. It needs to be timely the next day. Now, how they do that, that's up to the practice to sort that out. That could be by email, could be by fax, but whatever method they use, it needs to be considered under the privacy principles, that there are no data breaches in that. I don't think any of us would accept posting it. Australia Post, at least here in Brisbane, can take 2 or 3 weeks to regularly to get through, on Express Post several days to get through. So I think they need to work out their communication methods. But at the end, they need to have timely reporting. Like a daytime practice, an after-hours service needs to have flexibility in what they provide. Their flexibility should be limited to non-routine matters, but some of those may need longer time, some may need shorter time, some may need home visits, some may not need home visits. But certainly there needs to be flexibility in that, and that can be assessed by the surveyor when they go out to an after-hours practice, looking at the appointment schedule, and making sure that staff of the service know that patients can request longer appointments if need be. 1.2b, as in a daytime practice, an after-hours service needs to have a workable and good triage system. Ideally, that would be by a clinician, a nurse, for example, but not always that case. Many practices in the daytime don't use nurses for triage. Much of the triage is done by the front desk staff, but they need to be trained in triage. And this would often involve a flow chart near the phone, pop gun, for example. Maybe a little bit different for an after-hours service than a day practice. But that triage system should be able to categorise the patient. Is it urgent in terms of calling an ambulance? Is it a routine matter? And then we would expect that the patient is told, go and see your own GP in the morning. Or is it somewhere in between? And the purpose of the triage is that whoever's doing it can slot the patient in. Do they need to come straight in, or do they need to get an immediate home visit? Or can it wait an hour or two until others have been looked after on the appointment system? And this can be assessed by the surveyor, looking at the system they're using for triage. But certainly for me, just having something by the front desk doesn't mean that they understand it. I would have thought ideally we should also ask whoever's doing the triage exactly what they understand by the triage, and to give us some examples. With the after-hours service, as in a day service, patients may call, and particularly if it's a very busy time, does need to be an answering machine, a message that will say call 000 in case of a life-threatening emergency, or if the phone is not answered for whatever reason, then there needs to be a message on that telling them to phone 000. Not 000, because 000 is actually can be confusing for some people as 000. And again, this can be assessed for day practices. We routinely phone after hours to make sure that there is a message on the message machine for the practice, and this could also be done for the after-hours service. After hours is an interesting space to work in, and I'll state that I've worked in the after hours for a long time, and we do need, for all sorts of reasons, to make sure we provide a safe environment for all our team members. And this is for people that, if it's a facility, a physical facility where people come in, then it needs to be sure that our staff are safe. It may mean, for example, that when it's dark and our staff at cars are parked in the dark out the back, that people will walk out with them. But also, it particularly refers to doctors that are doing home visits. Many after-hours services will offer a driver who in reality is an escort for them, and at times a chaperone. And this is certainly a good system for after-hours doctor. Not essential, but desirable. Other means that they can use to ensure safety is to get the on-road doctor to check in on a regular basis to the service to make sure that they're okay, to maintain a list of what I might call problem patients, patients who may have been violent in the past, that doctors shouldn't really see. And if that's the case, then the service needs to offer alternatives, such as going to the hospital. Needs to maintain a list of people who are known to be drug seekers. Also, if a home visit doctor is going to a home, then we would advise, and we should make sure this is done, that any Schedule A drugs are not with them, but they're kept locked in the car. They may be used later on, but that would mean the doctor would need to retrieve them, but they shouldn't be taking them into the practice. As I say, the after-hours space is interesting, but is potentially dangerous at times, and we need to be aware of that. And all after-hours services need to be sure that they're providing a safe environment for their staff, ranging from their induction system to the day-to-day operations of the facility, to their on-call doctors who are on the road visiting patients. Home and other visits. Some after-hours services or deputising services only do home visits. So patients are accessing home visits because there's no physical facility. But other after-hours services do have a physical facility and prefer to see patients in that physical facility. But there are going to be times that patients do need a home visit, just like at day practice. And then it would be up to the practice to have a policy in place to delineate under what conditions they will do home visits, what they see as being safe, and what they feel as being reasonable. And this is the same as a day practice. Day practices need to work out what they call what is reasonable to do a home visit on and what is safe to do. But the after-hours service, as in the day practice, needs to cover all of these issues. And when a surveyor is assessing them, a surveyor needs to make sure that home visits for the practices that operate out of a physical facility are in fact done. And that means looking at the records, looking at the item numbers of billings if need be.
Now I'm going to talk about the next indicator, which we're running through, which has to do with continuity of care. So that's criterion 1.5. Now this states that our service or after our service encourages continuity of care with the patient's regular GP. Now Glenn has already run through that point with you. So to meet this indicator, you must demonstrate the methods that you use to communicate with the patient's regular GP, or back to the patient's regular GP, ideally the next day, as Glenn has said. So criterion 1.5b, our service facilitates the transfer of care of a patient when it's not appropriate for that patient to use our service. So to meet this indicator, you must transfer the patient's care to another practice or service when you think that's not appropriate. So that would commonly be to transfer the care of a patient to an emergency department, but not necessarily limited to that. And you should be able to provide evidence that your service is able to do that. So criterion 1.6, this slide and the next one talks about follow-up systems. So it's important that your service deals with pathology results, imaging reports, investigation reports, and clinical correspondence initiated by the practitioners in your service. It's important that they are reviewed, that they are electronically annotated, or if recorded on paper, signed or initialed, that they're acted upon by the referring after-hours practitioner, so that if the doctor orders an investigation, that the referring doctor follows up on that. That result is incorporated into your service's patient health record, and that a copy goes to the patient's regular GP or practice. So to meet this criterion, you need to be able to demonstrate the process that you use for practitioners in your service reviewing and managing test results. And you need to be able to demonstrate your process for copying results to the patient's regular GP or regular practice. So 1.6b, practitioners in our service who request tests ensure that clinically significant results are followed up in a timely manner. So if you get a clinically significant result back, you must attempt to contact the patient about that, and you need to have that documented in the patient's health record that you hold at your service. So continuing on the thread for following up test results, criterion 1.6c, patients are advised of the process that your service uses. So you must be able to demonstrate that your patients are given some information about how you intend to follow up any tests or results that they may have as a result of their contact with your service. 1.6d, our service alerts a patient's regular GP practice of clinically significant results. So if you do encounter a test result that needs to be flagged, then you must demonstrate how you do that, how you alert the patient's regular GP or practice of clinically significant tests and results. So again, the standards do not advise you or prescribe how you do that, but you need to be able to demonstrate to the surveyor the methods that you use. We'll just move on to the next criterion, which is engaging with other services. So 1.7a, our service engages with other health services when urgently required. So you need to be able to demonstrate to the surveyor that your staff are aware of the local healthcare providers who you have in your area, and so that you can use them or interact with them as appropriate. 1.7b, your referral letters need to be legible and contain all the required information. So when your after-hour practitioners make referrals, you need to provide evidence of the referrals in the patient notes. And the logical flow from that, 1.7c, your service ensures that the patient's regular GP or practice is advised of any referrals. Now, you could meet this criterion by demonstrating how you keep copies of the referrals letters that you provide to the regular GP, or you could demonstrate that you've appointed a staff member who has the responsibility for copying the referral letters and sending them to the GP's, to the patient's regular GP, which is specifically around the qualifications of the clinical team who are going to be working in the after-hours space. So after-hours criterion 2.1 is entitled Qualifications, Education and Training of Healthcare Practitioners. So 2.1a, members of our clinical team in the after-hours service need to have current national registration where applicable, be accredited or certified with their relevant professional organisation, have actively participate in CPD relevant to their position and in accordance with their legal and or professional organisation's requirements, and have undertaken training in CPR in accordance with the recommendation of the professional organisation, or at least every 3 years. So the service needs to keep records of current practitioner registration, of the continuing education that the practitioners have undertaken, and keep a record of CPR training undertaken by members of the clinical team. So 2.1b, GPs who work in the service are one of the following. So either a specialist GP, a general practice registrar with appropriate supervision in accordance with the standards for general practice training, be medical practitioners who are actively working towards fellowship on a recognised general practice pathway, or medical practitioners with more than 10 years experience in Australian general practice. So to meet this criterion, the after-hours service needs to provide evidence that their GPs are appropriately qualified, demonstrate that registrars and other medical practitioners are on a recognised pathway to fellowship under appropriate supervision and in accordance with their relevant standard, and demonstrate that medical practitioners who have worked in Australia, or that they're medical practitioners who have worked in Australian general practice for 10 or more years with the required experience. So continuing on with that particular indicator, 2.1c, the clinical team needs to be trained to use the services equipment that's relevant to their role. So that should be fairly straightforward, that you provide evidence that your team members have had training for the equipment that they are required to use. 2.1d, our clinical team is aware of the potential risks associated with equipment use. So again, you need to be able to demonstrate the clinical team have been educated on safe manual handling of the equipment that they're required to use.
So we'll continue on to Standard 3, facilities in our service. And I'd like to invite Angela Mason-Lynch to talk to us about these indicators.
Yes, thank you, Angela. I get to talk to you about the service facilities. And this is a really interesting area for after hours and deputising standards, because we recognise sitting around the table talking about the standards or developing the standards that some after hours and deputising services actually predominantly home visits. So we had to consider that while we were looking at the facility, the facilities. However, I do want to say to everybody now that even if it is just a home visit service, there are still lots of considerations that that the members of the service need to be thinking about. So let's just work through them, and I also want to remind everybody that the explanatory material in the standards is your friend. It has everything there that you need to know. So as you read through it, it gives you lots of options. And remember, of course, that the indicators that have the little coloured in arrow, there's something that you must do, and then if there's a no arrow, then that's an aspirational indicator. So let's work through them. After our standards 3.1, our physical service facilities are fit for purpose. So remembering that you are being assessed by your peers, and these standards are specifically worded so that you can explain how your facilities are fit for purpose. So what you must do to meet this indicator is demonstrate that your service's physical facilities are fit for purpose. But if I'm a surveyor looking at a service that predominantly does home visits, what I might think about here is some of the discussions that you might have with your doctors about, allowing a patient privacy even in their own home and things like that. So some of the you coulds under 3.1a are you could structure the facility layout so that it includes consulting rooms, toilets, hand cleaning facilities and areas for administrative functions, a triage centre, storage for medical supplies and so on. You could maintain reliable heating, you could maintain supplies of all necessary equipment, vehicles used for travel and so on. So all these coulds are documented in the explanatory material. So those are the sorts of things that you would be explaining to your surveyor when they're there looking at your service. 3.1b is all around our service ensures that all patient consultations take place in an appropriate consultation or examination space. So again, what you must do here, and you can see this one's got the little coloured in arrow, the little flag, you must be able to demonstrate that that this takes place, that it's, you know, that the consultation is in an appropriate examination space, if you like. So some of the you coulds around this, maintain privacy, you know, for the patient. You might think about auditory and visual privacy, and you might think about this even in a home visit situation. You might design the layout of the consultation space to ensure that there's confidentiality. And this might be something that an after-hours service would put in their induction for doctors, so that doctors are actually thinking about this when they're out visiting patients, as well as thinking about it while they're in the service in the facilities. 3.1c. This is our service uses consultation spaces that permit privacy and confidentiality. It's basically doubling, very similar to the indicator above. So again, it's just thinking about you know, what the patient would feel comfortable with as far as privacy and confidentiality. And again, having those conversations with practitioners so that, you know, even though you're going into a patient's home, that you need to be considering this. Some of the things that you could do here when you're talking to your surveyors is you could show them privacy screens that you've got in your facilities. You might talk to them about how you ensure auditory and visual privacy for your patients, and how you demonstrate that in a home visit or in the site visit. 3.1d, our service has a waiting area that accommodates the usual number of patients and other people who would be waiting at any given time. So you must demonstrate that there is an appropriate waiting area. So some of the you coulds here is, you know, just making sure that there are enough seats for the patients that you're seeing, making sure that reception staff can monitor the waiting area. Those are the sorts of things your surveyors will be looking at there. Just moving on to the next slide, and I'll take questions at the end of this because there's only a few indicators here. So moving on to 3.1e. This is our service has accessible toilets. Again, this is talking about you know, when you actually have physical facilities, and it really is self-explanatory. Some of the things that you could do here is you might separate toilets, you know, separate the staff toilets from the patient toilets. You could have appropriate signs. These are the things that you could show to surveyors to ensure that you are meeting this indicator. 3.1F, our service has accessible hand cleaning facilities. So you must provide this in your physical service facility, but you could also talk about this, how you manage this for home visits as well. So you could document your services requirements for effective hand cleaning during consultations. And you know, this might be something, if you're doing a lot of home visits, you might decide that part of the doctor's bag is some sort of wipes, you know, alcohol wipes or something like that, just in case the doctor doesn't have access to wash their hands during a home visit. But it's about opening up that conversation with a doctor as well, to consider that when they're leaving, arriving and leaving from a home visit. 3.1G, our service is visibly clean. So again, this is a mandatory. You must be able to demonstrate the methods used to maintain cleanliness of your service. So some of the things that you could do here when you're showing the surveyors you're meeting this criteria is you can ensure the vehicles used for home and other visits are visibly clean, particularly in the area where medical equipment is stored. You could use a written agreement with commercial cleaners, for example. You could use a cleaning log. You could provide washable children's furniture and play equipment. You could ensure the operations facility is visibly clean, particularly when where medical equipment is being stored. Criterion 3.2 is about the equipment and the doctor's bag, and this is really important that that doctors can do their job properly, and they can only do that if they have the appropriate equipment. For services that are providing care outside normal opening hours that only provide visit-based care, indicator C is really not applicable here, and this happens quite a bit throughout this area of the standards. There'll be some that are really not applicable, and that's quite okay, going back to the fact that your peer is assessing you. So 3.2a, our practitioners have equipment for comprehensive primary care. So you must provide evidence that all required equipment is stocked. And there's a really, really specific list for you in the explanatory material that tells you what you should have, what's appropriate for your doctors out there doing home visits or working from the facilities. Some of the you coulds for this one is you could maintain a checklist, you could maintain an equipment register, you could perform regular audits, you could perform a regular audit on the doctor's bags, and you could actually show the surveyor your typical doctor's bag as well. And you will probably find that they will be asking for that. 3.2b, our service maintains our clinical equipment in accordance with manufacturer's recommendations. So this is in line with what's in the standards for any general practice. So clinical equipment really needs now to be maintained, and that might be a very basic maintenance program, or it might be really quite in depth and need a special provider to do that maintenance. So you must be doing that, and how you could show that you're doing that is you might have a maintenance log that shows that, or you might have documents somewhere that shows that somebody is maintaining that and when it's being maintained. 3.2c, our service has one or more height adjustable beds. As you can see, this is only applicable to if you're seeing patients in a facility, in a physical facility, and that's fairly self-explanatory as well. 3.2d, our service has timely access to an ECG machine or an electrocardiograph, so you must provide evidence of this. So maybe your evidence is that your staff know how to know where the machine is, or it could be your staff and your doctors know where to refer a patient to if they need an electrocardiograph in the after hours period. Moving on to 3.2e, which, as you can see, is an aspirational indicator. It is not flagged. So our service has timely access to a defibrillator. So there's no musts in this, but there are quite a few coulds. You could provide evidence that the service has a defibrillator, and remembering you're being assessed by your peers. And I would think that being in the after hours period, it probably would be very appropriate for an after hours service to carry a defibrillator, and a peer would maybe make that a very strong recommendation if you don't have one. You could conduct a risk assessment to determine if a defibrillator is required on site. You could provide evidence that service providing home and other visits have a mobile defibrillator or AED. And you could ensure service staff can explain how defibrillator services are accessed by patients when required. 3.2F. Each of our practitioners has access to a fully equipped doctor's bag for visits and emergency care. This was discussed quite heavily around the table when we were looking at the standards, and there was a lot of feedback we received on this as well. Really, really important to make sure that the doctors have the equipment they need to do their job, and have a sufficient number of doctors' bags for the number of practitioners out there. So surveyors here would be actually looking at how many doctors are out on the road at one time and making sure that the service does have enough doctors' bags that are fully equipped to give to all those doctors to provide the service. You could ensure that your practitioners are familiar with the medicines included in the doctor's bag. You could ensure that the clinical staff can explain how to equip the doctor's bag. You could maintain a checklist. You could perform a regular audit for yourself or for the service. Are there any questions about the equipment that we're expecting you to have as part of the standards? So we'll move on to infection prevention and control, including sterilisation. So 4.1A, our service has at least one clinical team member who has primary responsibility for coordinating prevention and control of infection, coordinating the provision of adequate range of sterile equipment, both reprocessed or disposable. Where relevant, having procedures for sterilising, for reprocessing on-site or off-site, and ensuring there is documentary evidence that this reprocessing is monitored and has been validated. Safe storage and stock rotation of sterile products, and waste management. So nothing different here from what you would expect it to do in an in-hours service. And often the question is asked, why do we need one person leading this if we're all thinking about it? The reality is that if there's not one champion, it does often get forgotten, and I can tell you that genuinely, because as a surveyor, I often see that when I'm out asking, you know, who looks after the infection control in practices. So your service must appoint a clinical team member with this primary responsibility, and they must stay current with that. 4.1B, our service has written a service-specific policy that outlines our infection control processes. So this is, you just must maintain an up-to-date service-specific infection control process. You'll notice a lot in the 5th edition standards that it's all very well to have you know, your rules and regulations, your policies and procedures, but what surveyors are looking for now, that you're actually making sure that those policies and procedures are real, live documents, that they're actually service specific and relevant and kept up to date. So some of the things that you could do to ensure that is review the policies on an annual basis, consult with your service team when developing your services policy, and conduct regular audits to confirm compliance with your services policy. You know, infection control is just too litigious and too important for it to be not managed really specifically and pedantically. And this is one of the areas that does get quite prescriptive, as Simone talked about earlier on. 4.1c, our service has a clinical team member who has primary responsibility for providing staff education and infection prevention and control. So again, this goes back to you must appoint a clinical team member who has this responsibility, and the responsibility for educating staff. And I very often ask the question of the person who's allocated this role in a practice, what have you done, because this is such an important role? And they'll say, oh, I haven't really needed to do anything because everybody knows everything. And I just think that's a really poor response. I like to see that these people are, that this champion of infection control is out there, nagging people to wash their hands and nagging people to wash the children's toys and nagging doctors to have, gloves in their car when they're going out for home visits. So some of the things you could do here is identify the team member who has primary responsibility, make sure that they've got it documented in their position description, make sure that they've had education, include infection control on induction, and discuss any changes to legislation and guidelines when, say, an outbreak occurs. So, what is the process for that in the business? And include an education component in the infection control policy would be a good way that you could convince surveyors you're serious about this. Moving on to 4.1d, all members of our service team manage risks of potential cross-infection in our service by methods including good hand hygiene, use of PPE, triaging of patients with potential communicable diseases, safe storage and disposal of clinical waste, including sharps, and safe management of blood and body fluid spills. So what I really like here is all members. Those first two words, really important, because very often, you see doctors filling up sharps containers until the sharps are overflowing, and that to me is not telling me that this service has thought about educating their doctors or ensuring their doctors are doing the right thing as well. So as a service, you must be able to demonstrate that the service team manages risk of possible or potential cross-infection, that you've got a safe, sharp storage and disposal, safe clinical waste disposal, that you've got plenty of PPE available for your team. Some of the coulds for this is you could have a policy and procedure, and if you've pushed that out and got your team to sign off on it, that's fantastic. You can maintain a cleaning policy, maintain a cleaning log, and again, you might discuss changes when they occur. 4.1e, patients are informed about respiratory etiquette, hand hygiene, and precautionary techniques to prevent the transmission of communicable diseases. So this, you must have a policy on infection control. You must have facilities for hand cleaning and all consultation and treatment areas. You must have tissues and rubbish bins available in the waiting room. You must be able to describe how patients are informed of the importance of respiratory etiquette. We've got to be responsible here about controlling, all those bugs that we invite into our premises. 4.1F, this is, you can see this one's not a mandatory one, this is an aspirational one, and this is about if you're doing sterilising in your in the after hours service, whether or not you are logging the sterilised equipment again, or sterilised equipment used against the patient's file. So you could record sterilisation load numbers in the patient's health record when sterile items have been used. You could have a log or list that records the patient's name against sterilisation load numbers. And I think that brings me to the end of infection control.
So let's now move on to patient feedback. and I'll hand over to Simone.
Thanks, Angela. So patient feedback really provides an opportunity for services to meaningfully engage with their patients to find out how they're going, where they're doing well, where they can improve further. There's a growing body of evidence which indicates that services and general practitioners that listen and act on feedback from their patients around their experiences of care can lead to improved health outcomes for their patients. There are opportunities for services to implement quality improvements within their service based on that feedback. And the focus should be on the outcome, the quality improvement activity, how the feedback has been used to improve the service, rather than get caught up in the process of collecting feedback. Just moving on to the next slide, under the 5th edition, patient feedback collection is far more flexible, so services can choose ways to develop their patient feedback tools or methods. There's much more flexibility, provided it meets the requirements that are set out in the patient feedback guide. It will be approved by the RACGP. Services can still use the toolkit and the commercial tools. It's probably also useful to let services and know that we're in the process of currently updating the RACGP toolkit. We did receive feedback that the toolkit is very general practice specific and isn't very after hours or medical deputising services friendly. So we're looking at doing a piece of work to update that to ensure that it is context specific and therefore more meaningful. In terms of moving on to the next slide, this is the picture of the patient feedback guide that we're looking at updating, and will provide greater support to services particularly those seeking to develop their own tools. And as I said earlier, there's much greater flexibility under the 5th edition to create a service-specific way of collecting patient feedback. Going on to the resource guide now. The resource guide's been developed as a supplementary resource to accompany the 5th edition standards. So this document has a wealth of information and links related to, broken down by criterion, covering the core, quality improvement, general practice, and after hours modules. And what we've done, and specifically where we've identified after hours resources, is we've denoted that with a moon icon so that after hours and medical deputising services can see very quickly which resources specifically relate to them. But most of the resources throughout the resource guide would also be of benefit. We've recently updated the resource guide, as we noted there were a number of broken links, so that will now be up to date.